Good morning, everybody. If I could ask the stragglers to take their seats, and I know more people will be coming in. Some sessions are still getting out. Good morning. Good morning. Come on. We've already had 3 sessions, 7, 8, and 9. You guys should be wide awake. I am Ruth Katz, Director of the Health Medicine and Society Program here at the Aspen Institute. The Health Medicine Society Program is a co-producer of Spotlight Health. We're delighted to have you all here, and especially to be here for this terrific session that I know that you're going to enjoy. It's my great pleasure to introduce again, actually, the woman and the journalist who needs no introduction. I know I keep saying that, Judy, but it is true. Judy Woodruff, who is the managing editor and anchor of PBS NewsHour, and I really don't think I have to say any more. With that, Judy, I'm going to turn the program over to you to introduce the panel. Thank you all for being here.
Thank you, Ruth. Thank you to the amazing Ruth Katz. I am delighted to be here this morning. It's great to see all of you looking bright-eyed and bushy-tailed, because I know, as Ruth said, you probably have been up since 5 o'clock, jogging and walking and doing yoga. This is I think, going to be a fascinating discussion, and I know you wouldn't be here unless you agreed, because we have 4 extraordinary panelists to talk about something that I think doesn't get a lot of attention, certainly doesn't get enough attention. The title, it's been given the title, Follow the Money, Investing in Health. And just to share what I think is already in your program, what the Aspen Institute has already said is that health investors may be venture capitalists, they may be people who are willing to take the big risk for the possibility of big returns. They may be foundations that use program-related investments to generate a return on capital while supporting their charitable interests. Or they may be social entrepreneurs who hope to do well by doing good. They come from different places, but what we know and what we're learning is that the investing in health space is huge. It was big, and now it is growing, and as you're going to hear, I think, from our panelists, it's exploding in size. But it also raises a lot of questions, and we're going to try to have that conversation this morning. We are, again, really lucky to have these 4 individuals. I'm going to start from my left on your, let's see, yes, on your left. As you look at the stage, the gentleman next to me, you all recognize, is Lanhee Chen. He is the research fellow at the Hoover Institution at Stanford University. He was an advisor to Marco Rubio's presidential campaign last year. In 2012, he was the policy director for Mitt Romney's campaign for president, and during the George W. Bush administration, he was a senior official at the Department of Health and Human Services. Next to Lanhee is Karl Manland. Karl is the Chief Operating Officer of the EcoBank Corporation. He is an economist with over 10 years of experience in health, in finance, and project implementation. He's worked with communities across the continent of Africa. He's developed systems to improve public health financing, mainly at the Global Fund to Fight AIDS, Tuberculosis, and Malaria. I also want to say that Karl worked with the Economic Commission for Africa and with the African Union and the new Partnership for Africa Development on a private sector initiative to assist the African Union fighting Ebola in West Africa. Karl Manland. Next to Karl is Anula Jayasuriya. She told me it didn't matter how I pronounced her last name. I promised her I would mangle it, and she said she would forgive me. I'm sorry, Anula. Anula is the co-founder and managing director of the Evolvance India Life Sciences Fund, an organization that invests in pharmaceutical, biotechnology, medical devices, and related contract service companies based in India. She's a native of Sri Lanka. She moved to the United States in 1976. She's had a lifelong interest in healthcare, in pediatrics, and in women's health. She has an MD and a PhD in microbiology and molecular genetics, as well as a business degree from Harvard. So all of these from Harvard. Harvard Medical, Harvard Business. We're in awe. And last but not least, on your far right is Dr. Mark Smolinski. You saw him yesterday if you were at the opening session with the 10 great ideas. Mark is Director of Global Health Threats for the Skoll Global Threats Fund. His work has brought together governments, NGOs, academia, and private industry in partnerships across national borders in Southern Africa, in the Middle East, in Asia, Russia, and Southeast Asia, and Africa. And as you did hear yesterday in the opening session, he's talking about stopping pandemics in our lifetime with a global disease reporting system, which I am sure we are going to hear more about. So let's start. I'm going to actually start kind of in the middle with you, Karl, and ask all of you to talk about what investing in health means to you. Why are you here on this panel? Why is this something that's important? How is it growing? What's your perspective on it?
Thank you very much. Why investing in health? It's a beginning of life. Why investing in health is ensuring that we can think long term in terms of how individuals contribute to the economics of the society.
You may have to talk louder here because we're getting a little competition from the music over there. So
okay,
don't be afraid to project.
Let me back up. Then, why investing in health? I think it's the beginning of life. It's where it all started, and we want to make sure that people have an ability to contribute to the economics and actually grow the economies. If we look at communities across Africa and we look at the recent Ebola outbreak in 2014, the first responders were communities. And if they had been given the tools to actually combat the disease early, we may not have seen what we had seen. So it's important that we remember that it's about people. And for us to be able to get to that point, from an African perspective, we need data. So investing in health from that perspective is to ensure that we have accurate data to inject where it's required the money.
All right, Anula, you next.
I can't think of investing in anything else. I'm a physician by training. It's my whole life. It's my passion and profession. So I think only about health. And so it was a very easy decision for me. I think it is fundamental to all of our well-being. And it's something that also is right now is at a very interesting time where the science is hitting a brand new level where we are being able to bring genomics into medicine, precision medicine. It's a wonderful time to be investing in health.
Lanhee Chen, you come at this from a somewhat different perspective as an academic and someone who analyzes. Why are you interested in this topic?
Well, I see entrepreneurs and investors who are making decisions about the deployment of capital, particularly in the healthcare space. And the thing that I'm most concerned about is the interaction of these investors with the regulatory system, right? Health is it's a regulated industry. No investor comes into this without thinking about what are the barriers that the regulatory system may potentially put in front of me as I seek to deploy my capital or I seek to make a bet on improving health or improving health care. So I think the fundamental challenge we have is that we have a regulatory system built and designed in the 1960s for an economy that's rapidly evolving and for investment that's rapidly changing, and it's quite dynamic. So I'm really interested in how do the two sides talk to each other. It's like, I used this analogy earlier, but if investors are from Mars, regulators are from Venus, they almost never speak the same language. And so how do we begin to get people on the same page to really sort of animate what's going to happen in these next several years and decades?
Mark, what about you? You're also coming at this from a different perspective.
Yes, so we invest in public health, and during this 1 hour, 1,000 people are going to die from an infectious disease across the globe. Half of those are children under 5. We can't think of a better thing to invest our money in at the Skull Global Threats Fund than solving that issue, on top of the fact that it's been estimated that 2 to 5 new emerging diseases, including antimicrobial resistance, which are essentially new bugs, are happening every year across the globe. So we're trying to invest in the public health systems that will improve the healthcare systems, because in most of the countries we work in, people don't have the access to the healthcare. And so in order to reduce even the burden of the people who go to the healthcare systems, we need to be dealing with the community health workers, the public health systems, and trying to really build that infrastructure so that we're finding these threats in these communities faster, because the smaller any outbreak is, the less of a burden it is on any healthcare system within that country. So we see our investment in public health also being an investment in health care, but really trying to reduce that burden of people who need to go to the healthcare system, because we could do a lot more with prevention and control in the community.
Carl, pick up on that and talk about what right now are you looking at that needs investing,
So
needs people to believe in it and put money into it.
there's a program in Rwanda called One Family Health, which allows nurses, and majority of them women, to actually own their own business. And this is important. It's about creating jobs. It's about allowing people that have the skills to actually use them to save lives. So what we have done as a foundation is to allow a loan subsidy so that they don't pay market interest rate. By doing so, over a period of 5 years, there's a discipline that is learned from a nurse perspective, but also business management and other skills that are important for her or him to understand how they fit into the economy. And I insist on that because people need to feel that by doing what they are best at, they can create jobs, they can allow the people to have opportunities to contribute to society. Health is key. And if we can continue to ensure that individuals have better access to health, being in the US or being in different countries in Africa or in Asia, we will probably see that the returns on investment will grow because people will actually be able to work in factories that will be created. And we should not disconnect the entire health as being something which is a standalone. Health is part of the whole picture.
And Anula, you laid the groundwork with what you said a moment ago, but give us some of the specifics of what you're looking. We had a conversation before we walked over here about how investing in health has changed, and I want to come to that in a moment. But right now, what is exciting to you? What is it that you would like to see more and more?
So one of the exciting things that is happening now in Africa is the Africa CDC, which was launched this year. The US eradicated malaria about 60 years ago, and that was the birth of the US CDC. Africa is at the point where it needs its own Africa CDC. And for that to happen, we already have the data. Everybody's working around the cell phone. So potentially this is information that we could collect. So if we want to see a change in healthcare in Africa, we need to be able to speak to mobile network operators so that we can collect the data as fast as possible. So there's data element, that's number one. Number two is about non-communicable diseases. A lot of investment has gone into HIV, AIDS, TB, and malaria. But we see that with lifestyle changes, with the millennials not being as aware about HIV, AIDS because the prevention work is not the same as it was about 10, 15 years ago, they don't think about HIV, AIDS the same way. So if we want to ensure that there's a change in the landscape, the Global Fund to fight AIDS, TB, and malaria has done a great job. Billions of dollars were invested consistently over the past 10 years for HIV, TB, and malaria. But now with NCDs, what is it that we're going to do? We can't always look at the West to get the money. Africa's middle class is growing. There are about 300 million of us. I include myself in that middle class. What can we do to ensure that we bring money on the table? And these are some of the elements that, of course, part of it is investment, but also changing the way we think about investing in health in Africa.
Anula, I want you to pick up on that because it is something we've been talking about.
By way of just context, I wear two hats. One is I invest in India, but it's not an impact fund. It's a financially driven fund, and as well as in the US. So in the US, I look at women's health, but again, financially driven because I think it's a gap in the investing market, and we can come to that. In India, we look at all sectors in health. And India is, as you just talked about, is very interesting because the use of telemedicine, for example, and solutions that use cell phones are far more penetrated than they are in the US. And there are some advantages with the regulatory, which you talked about, Lanhee, both pluses and minuses in that you can bring diagnostics, for example, which are very much needed in the US, but financial investors are not investing in them because of the arduous regulatory process.
What's an example of that?
You can just take any diagnostic. The issue with diagnostics is that they have the same regulatory path as a drug, but the reimbursement for a diagnostic is much less than for a drug. So every financially driven investor looks at a drug rather than looking at a diagnostic. Likewise, in medical devices too, right now, for different reasons, because the market of buyers in the medical device industry has consolidated, and because the innovation cycle in medical devices is just to do incremental improvements.
Right.
That's also an area that's not hot for investing, whereas in India, you can do that. So what I like is being in two places where I can see how emerging markets deal with it, even though we're looking at financial returns and not what you're doing, which is very much needed. It is to be able to compare and contrast, especially on regulatory, what should be there and what shouldn't be there.
And well, I want to go to Mark now because
Yeah, I'd like to comment on these. If I could have a wish of what people could invest in healthcare, despite the issues that you're talking about, it's diagnostics. I mean, it is our #1 challenge in trying to fight outbreaks, because we have outbreaks that happen in parts of the world where 3 endemic diseases are already circulating. If we can't weed out the 3 known diseases in a given country, we're never going to find the next SARS or the next MERS or, God forbid, another HIV kind of, virus coming in that once it comes in, we live with it forever. HIV is arguably the biggest pandemic in the world. And, once this evolves and it spreads, even something like West Nile, came to the US for the first time in 1999. Within 3 years, it's now an endemic disease throughout the US. So we have to have diagnostics, because what we're doing is we're losing all of that time, because Ebola was, part of that was the issue. They didn't know what it was. They knew there was something on, but they thought it could have been loss of fever. They thought it could have been many of things that happened. So that's such a critical issue, and I understand the regulatory issues, and I understand the investment in drugs, but without diagnostics, we're also wasting the drugs that we have. And, we're treating people in countries where, my tuk-tuk driver in Cambodia, where I lived for 2 years, one day he says, yeah, my wife's not feeling well, we have to stop at the pharmacy. So when he came back, I said, David, let me see what you have. And I took photos of this, and literally 2 Cipros, 3 amoxicillin, 4 Tylenols, and all of that was taken by his wife. That's not how we solve the issue. So while companies want to invest in drugs, I get it, they're used more often than a diagnostic. But the point is, we're driving up resistance because partially treating someone without a diagnostic, if they did have one of those diseases but only got like 2 pills as opposed to a week course, we're driving up resistance. So it's so critical, and I don't know how we solve that issue, but it's paramount.
So you've put your finger on one of the misaligned incentives with traditional venture investing. And that's why having people like you who do look at public health, we are not wearing my financial return hat, but wearing my humanist and doctor hat, are very reliant on people like you to make that difference. And it is to my chagrin that the preventive medicine, preventive care, public health, and diagnostic, which go into that, are not areas that are suited because of the regulatory and other reasons for traditional healthcare investing.
Lanhee, are we really talking about 2 different universes here? I mean, the United States, the developed world, which is looking for, the most advanced immunological developments you can imagine, whereas the rest of the world is looking for, as we've been hearing, some of these basic things like diagnostics, which aren't getting the attention they deserve.
Yeah, so much of what happens developmentally here in the US is driven by models of compensation, much of which, frankly, government still drives. So if you think about how innovators are making decisions about new cures, they're largely thinking down the road. What is the Center for Medicare and Medicaid Services going to do in terms of compensating for this particular cure? How is the Food and Drug Administration going to approach the drug approval process? How arduous, how time-consuming is that going to be? Because remember, for every winner, there are tons of losers. And that amount of risk requires, I would argue, sort of a different model in terms of thinking about how we're compensating the risk that's taken on the front end. So we do have some challenges, I think, from a regulatory perspective that disincentivize the kind of development that we want to see that are going to do good things here in the US, but also abroad.
Right. Why is there still this reluctance or maybe it's been there forever, to invest in the kinds of things that, that Mark and Anula are talking about?
Well, I think the simple answer is, that's not where the money necessarily is. There are people who I think are taking a broader view. But at the end of the day, the United States, we incentivize innovation here for countries around the world. We as American taxpayers absorb the cost of some of that innovation, and arguably we should, because we're in a better position to maybe than other people are. But we need to be figuring out how to do more of that at a systemic level. Now, part of that is, are we investing in the right way from the government financing side? Are we investing in our government institutions that are going to promote this kind of research?
And that gets to a question about government versus the private sector. But how have decisions about investing, Karl, changed over time since you got into this arena?
I think I'll start on what Anula said. Let's say your investors want a 20% return, and then you make 25. Are they willing to share the 5%? To invest in the kind of...
We'll put it to good use.
To invest in the kind of diagnostics or tools that will allow for more people to have access to better healthcare. And I think that's an important question that people that are making more than they expected to should think about. On the regulation side, when you speak about compensation, most African countries don't have a compensation system. So it's mainly out of pocket. So yes, the innovation comes from the US, but those that bear the brunt of the cost are actually mainly in developing countries. And from that perspective, very few countries, Rwanda has a national health insurance scheme, Ghana has one, but in terms of compensation, there's none. So it's really out of pocket. So how do we ensure that the person that goes for out of pocket gets the best diagnostic and the best care? So if you're living in the slums, let's say in Kibera, in Kenya, or if you're actually going to the best hospital in Nairobi, can you have access to the same quality of care? The answer is probably no, but you're still paying for it, and there's no compensation.
So what's to be done?
Well, we need to certainly look at how, again, people get access to better jobs. We cannot disconnect the fact that because I have a good job and because I've managed to kind of get my way in society, there are certain things I don't ask myself. My children are vaccinated. Can we ensure that people actually have access to jobs? So creating jobs, meaning that we're not just looking at health. Health is one element of what is required. But overall, if we create jobs, we may not be having this conversation.
There's a silver lining. So first of all, people in the US need diagnostics that they're not getting. So this is not just a developing world problem. Right. And people in the US need prevention, not just a developing world problem. Right. And so just to make sure that everyone understands, and it's affecting Americans as well, this incentive misalignment. But let me give you two examples of silver lining. So prevention, it's been a big problem for traditional venture capitalists to back companies in prevention traditionally, because that's not where the money is in treatment. It's a systems problem. So, but there are let me give you two examples of new companies that are beginning to crack this problem. So one is in the diabetes space. So there is, I'll name Omada Health, there's Gluco, there are several. Right. But they're using digital health as a way to prevent flare-ups of asthma and diabetic disease. They've raised a lot of money. They've been very successful, and they help patients manage their disease and compliance and so forth. So that's a silver lining, where finally there's a business model, maybe, in prevention.
U.S.-based company? U.S.
Yes,
company.
These are, the Propeller Health is for asthma. Yeah, so there is, from this digital health perspective, because it reduces the costs of having humans or nurses or people having to go to a central facility for their treatment and monitoring. This allows patients to be monitored in place. And so this is very encouraging to me, because if you're a financial investor, it's all about the business model. And digital health is changing and allowing these business models to flourish. So it's a very exciting time.
How much of investing today is done by governments, and how much by individuals who are looking to make, or NGOs, will be pushing for the kinds of things that we heard Mark describe. But how much is done by governments and how much by the private?
Are you asking me?
Yes.
Okay, so in the US, the NIH is the biggest government investor in new technology, DARPA, some of the other agencies. But the bulk of the traditional venture investment comes from private capital. The foundations are another sector that works in, like Gates Foundation, Skoll Foundation, and many foundations. Gates actually also has an investment fund, but it's a small activity. So there aren't, as Karl brought up, there are a few impact funds. And what that means is that you are giving up some of the returns in order to do good rather than trying to get the best return. And that's an emerging sector, but they haven't had a huge influence yet, but it's an emerging area.
Mark, how do you move the current landscape of investing around so that you begin to solve some of the problems you're describing?
Yeah, so not everything in public health is just charity. And, what we're trying to do is look at, the innovations with digital technology has certainly helped us in disease surveillance. And the countries that we work in, the tools that we help develop, our theory of change is we need to apply the technology that already exists that you're hearing is helping the healthcare sector, the academic sector, the business sector, but we're not seeing that influencing the public health sector across the globe. So
Why not?
Quite frankly, there's just no resources in public health just to do the traditional public health. So the idea to have the capacity to think about innovating. So what we do is we go into a country and we say, look, we get it. It's very high risk. Nobody knows whether you ask the public to give you symptoms of illness, is that reliable? So there's so much uncertainty in innovation that we say, okay, we will take the financial risk as a foundation as long as you are a partner in this project and that you understand that we're here to help you adopt technologies that already exist, and we will help you, and we will find developers in your country. And that's what's most shocking to the ministries, is we have these processes where we bring developers in a 3-to-1 ratio to the ministries of health and agriculture, and they spend a week together. And the developers are all from that country. And on the very first day, the health ministry and the agriculture ministry, because we believe in one health. Zoonotic diseases, if we don't merge animal and human health, we're just so far behind the 8 ball. So they tell their problem to the developers. Then the developers go on a field trip with them to see, oh, okay, you're trying to get real-time data from this clinic or this hospital or this village. And then the developers lock themselves away for 3 days and they hack away and develop prototypes. And then at the end of the week, we fund the most promising prototype because it was developed by the government with their own developers, all open source. And when we leave, that union, we didn't even know we had developers in our country, because they were in the private sector or they were, working for a big NGO. But when they saw the opportunity to come together and help, that's how we're seeing change. And in a lot of these communities, some of the developers that we've started, we may have been the first one who ever invested in them. And some of them have then gone on to become a for-profit venture. So we're trying to see how we can scale some of these processes by, in some ways, creating businesses, in public health, because technology is providing a whole new sector of young people who are coming in and thinking the same way social entrepreneurs have helped across the whole field. Now there's social entrepreneurs are basically looking at that technology and figuring out how do they apply that technology, which is a great business opportunity in many of these countries.
How do you increase interest and investment where you need to make it, Lanhee? What needs to happen? Again, I know you're speaking from outside the sector, but what do you see?
Well, it's all about the alignment of incentives, as I see it. And I return to the point that, particularly here in the United States, so much of this decision-making is driven by government agencies. It's driven by what the Center for Medicare and Medicaid Services is going to do, how FDA is going to approach the approval process. And so we've got to get the incentives aligned right. Now, in some ways, that means migrating our healthcare system away from one that thinks about sick care and one that thinks more about well care. And how do we incentivize that on the front end? The answer is we've got to figure out whether the money is really there, whether government's going to start thinking about compensating for public programs like Medicare and Medicaid in a way that incentivizes the development of technology on the front end. I mean, I'm all for another app that tells me how many steps I've taken or how stretchy I am when I do my yoga. But that at the end of the day, I mean, we've got plenty of stuff there. There are many other spaces in that sort of preventive area where I think we could be doing more work and where government could send a signal that, look, this is something we're going to value and frankly, we're going to compensate for.
You're talking about the U.S. government.
The U.S. government, I'm sorry, yeah, the U.S. government.
Carl, you want to jump in on that point?
There's a lot of money in health to be made. There's medical tourism, people going to India, Asia, from Africa to be treated, and they pay cash. So the question is, can we create the same possibilities for Africans in Africa? And if we do so, we will see that more jobs will be created. Because for you to be able to innovate, you can do so because you get the data on the type of diseases that you continue to see and on the type of needs that people in that particular area have. But if we just continue to just transfer technology from America and other places in the world, we're missing a point. Because the disease is not all waiting for what's happening in America to kind of evolve in Africa. We've seen it with Ebola. Very quickly, rapidly, it changed. So what does it mean? We need to localize the needs that we have in Africa. And we can certainly, as Africans, start paying for it. And I insist on that because the conversation will change when others will stop seeing us as just recipients.
But it's consumers, right?
Yeah, consumers part of it. Now, on the consumer part, McKinsey tells us that by 2020, the African middle class will be spending trillions of dollars on stuff, iPhones and the rest. It's nice, but it's not creating the kind of jobs that we need in Africa because it's all imported. So part of the conversation is saying, at which point do we now use agriculture as a mechanism to ensure that people have jobs, agro-industries, so that by the time we start talking about healthcare, it's not the kind of disease that people get because they are poor. And we can prevent them, the rest, diabetes and the rest.
To Carl's point also, looking at it from a genomic perspective, most of the data that we currently have is based on Caucasian populations, and there's also a similar disparity amongst male and female. We know much less about female biology than we know about male biology. So we have to address the diseases of other countries as well as understand the ways in which they might be different in their in the way they react to or are susceptible to disease. For example, people of South Asian origin, which is a big bucket, has 4 times the cardiac risk. They can be normal. They can have a body type that looks completely fine and drop dead, whereas it would take a very different body type for a Caucasian, for example. And so,
But your point is there's not enough research that's been done.
that's right. And because much of the research has come from the U.S. and U.S. has invested in the research, so that makes sense. But we are then also exporting interventions that are developed for one population, just as we have done for women, using drugs that were developed for males, using them as if they were equally effective in women. The same way, we're also having that same blind spot. It's not intentional, it's just a consequence.
Yeah, and one of the ways we're trying to increase investment, I'll give you an example in Thailand. So when we create this EpiHack and we have a process and now this community where we started this in one province and we brought the government and we said, this is high risk, but when it looked very promising, we were getting great results, then the government got more interested and we said, okay, but they were like, yeah, but that's just one province. Can you actually replicate that in the 2 neighboring ones? So we gave more support and said, okay, but if it makes it in these 3, will you take it countrywide? And they were like, yes. But more importantly, they had never thought about reaching out to corporations within Thailand. The Thai Health Promotion Foundation, which gets $100 million a year from tobacco and alcohol tax, they only promote health promotion. So we took companies from Thailand and we took the Thai Health Promotion Foundation to the community to see what they were doing. And all of a sudden, this company's like, we have to invest in this. And the Thai Health Promotion said, oh, we didn't think disease surveillance was part of health promotion, but now we see that you're giving these communities all this valuable information, which is all about prevention. And they were like, we absolutely have to fund this. So part of it is letting people within these countries know that there are opportunities and that they play a role in that community. And it's really important for them to be part of this process. And just opening those doors and allowing the ministries to have conversations in many countries that they've just been uncomfortable to have.
So it's getting away from that paternalistic
Yes.
view that the U.S., it's all coming from the U.S. or the West, so to speak, that there's a lot that can be done there. One or two of you were telling me before we came here this morning about China playing a much bigger role internationally. What do you see?
So I was talking about drug development in the U.S.
Right.
So there's been a lot of interest from very large Chinese funds in investing into novel drug development companies in the U.S. And China has just opened a Chinese incubator in near MIT in Kendall Square, which is sort of a hotbed of life science innovation in Cambridge, Massachusetts. And I'm seeing a lot of Chinese investors coming and putting in hundreds of millions of dollars. Another very big investor who has come into the U.S. In a big way is the investment fund of the government of Singapore. They put 800 million into Verily, which is Google's life science company, and they're putting hundreds. So the government of Singapore currently has only 2% of their huge sovereign wealth fund in healthcare. They want to go from 2 to 6%, and it's called Temasek. And Temasek wants to do that in the U.S. So there are big investors coming into the life sciences primarily, but also AI, digital health space from outside of the U.S. coming into the U.S.
AI, so artificial intelligence, right?
So there are huge applications in medicine, and that's a very exciting new area. And Google and many others are in there.
Okay, we're going to come to the audience in just a moment, but I do want to ask all of you about, just in general. Most of us who aren't scientists and don't spend a lot of time on this don't think about how medicine. We know medicine has changed. We know there have been advances, but we can't even begin to comprehend where it's headed. So when you talk about artificial intelligence and some of the other newer frontiers of medicine, it's pretty daunting. And I guess I
think it's very exciting.
It is exciting, but I do want to come back to this question of the United States versus other places. How much does it matter that these investments are happening here or end up landing here in the U.S. or that they land somewhere else? Does that matter? Does it only matter that it gets done?
Well, I think it says something that so much of the investment in health right now is inbound to the United States. The Temasek example, the Singaporean Sovereign Wealth Fund, is a really good example of this. That a lot of the Chinese investment is driven by China's Sovereign Wealth Fund, which is huge, and they have made the decision that rather than investing in native innovation, and there is innovation happening in those places, they are really curious about what's happening in the U.S. But the one thing that they keep coming back to is we would love, this is now them speaking, we would love to deploy more capital in the U.S. But the challenge is we have no idea what's going to happen because you have such a messed up political system, this is their perspective, and a messed up regulatory system that doesn't provide us with any certainty as investors. So how do you want us?
But we're still coming.
But they're coming anyway, which just gives you an idea of how dynamic our biotechnology, our device, so many different sectors are so dynamic in the United States right now. And that's why they still want to come here. So my view, I guess, to answer your question, Judy, is that I think a lot of it happens here because there's just so much innovation happening here. And to the extent that it happens elsewhere as well, great. But we have to be realistic about the fact that a lot of it is happening here, and that's okay.
Anybody else on that?
I think that also I'm excited about these new funds coming in because I think they will also change the somewhat narrow aperture of the view of the world is all Caucasian. I think that will, they will bring in, when you're putting in $800 million, I think you get to say a little bit about how things are. So I think I think this is good news in multiple ways, and I think that their investment has a long horizon in that they're not just thinking about being in the U.S. They are looking also ways of then repatriating that back to their areas, and there is more. So there's more happening in China, in life sciences, and India, and other places, and in Africa. I'm sure you're just not familiar with it.
Does it end up addressing the problem you described earlier about not enough investment, not enough innovation in diagnostics? Or is this all the way future frontier?
Yeah, so
Funds are
it is possible that this diagnostics will tip back to a better place. We're not there yet, but I'm optimistic that it's going to happen. Another area that we talked about that the U.S. needs, this is not just a problem for faraway places, is antibiotics. So in the 70s, from the 60s on to about the 90s, the U.S. had lots of innovation in antibiotics, and then it stopped because it doesn't make money. So it's a problem that all of you suffer from, not just people in Africa or India.
Okay, questions from the audience? Right here, white jacket, and then we got another one over there. Got a microphone coming. Could you stand up and tell us your name?
Tara Montgomery, Civic Health Partners. I'm a healthcare innovation person, but a lifelong consumer health advocate. And my concern is that so much of the investment at every level is going into the sexy new things at the expense of equity and access. And it was even depressing to wake up this morning and see healthcare stocks went up after healthcare access is threatened to go down. So what's the message to investors to think ethically about the balance between investing in more people getting access to drugs and insurance and innovations versus getting out there and doing the moonshots and the artificial intelligence and so on?
You want to direct it to one person or whoever wants to tackle?
I'll pick you on the left. I think you might have an interest.
Okay.
Lanhee, I think she means you.
Yeah, no, the first time I've ever been described as being on the left. That works in Aspen.
I remember that.
It doesn't work anymore. No, look, I think that we do have one of the biggest challenges we're going to face as a healthcare system is how to make sure that all these great things that are happening are accessible to more people. I completely agree with that. I think the question becomes how we speed up that innovation. So I'm really interested in that side of this. How do we speed up the innovation cycle so that we're seeing more cures and more developments so that we can have a marketplace that's fuller versus a, shall we say, sort of forced redistributional solution. I think it's two different arguments, and some will argue that what we need is the latter. That's just not how I personally think we're going to get to a point where access is broad-based, because eventually my concern is with a top-down solution, we're going to stunt the kind of innovation that we really need and want in our society. It's a really difficult balance. And I'm not saying we've got it right now, but I am worried about where that balance is struck.
Anybody else want to weigh in on that? Okay, I thought I saw a hand over here, and there are several hands over here. Let's see.
Thank you. I'm Rachel Nugent, RTI International. I was delighted to hear Karl mention non-communicable diseases in developing countries. It's something that's still kind of far off the radar screen for a lot of people. But with respect to the theme here, investing in health, it is beyond my ability to understand how we, as the world, global health can invest so much in the infectious diseases, maternal and child health, only to see people dying very young of these chronic diseases. You know, we're not making the most of those investments. So I wanted to ask maybe Karl or others on the panel, you know, innovation that you're talking about is coming up with great products, but that's one way of innovation. You know, is it going to be able to reach a price point that can be accessible to people and ministries in those countries? Or what about products that are redesigned or developed especially for those markets? How, you know, are we getting closer to that, in your view?
Probably not. And I think where we are today, if you look at the bulk of funding that goes, is still for infectious diseases, HIV, TB, and malaria. The responsibility then falls on us as Africans to make those choices. I'll give a different example. A lot of children are stunted. So it implies it doesn't matter how much you invest in education, they're useless. So for the NCD perspective, it starts with what people eat. people were used to a different diet. Suddenly you have KFC, McDonald's, and all these nice things that show up. You don't have time for your family. You don't have time because you start buying, you don't exercise, you change your lifestyle. All these things have to do with what we call now the African middle class. Now, people also suffering from NCDs in rural areas. Why? They used to walk to go to the place where they work, which is on the farms. That has stopped as well. So those changes are brought on by what we call globalization or what we call advancement. But we have not actually taken stock of what it means for us as Africans. We just jump on the bandwagon, we could just continue. And this is a challenge. And I don't expect others to be funding this to us. First, it's an individual responsibility. What we eat, how we do it, is a choice that we make. But some people don't have a choice. Because if you don't have anything to eat, you eat what you have. So to your point, no, we are very far from it. And it's a silent killer.
Let's see, who? Right here. Yes, this gentleman in the second row. Oh, Larry Brilliant.
Hi, Larry Brilliant. Jai, I was really pleased to hear you talk about impact investing funds. And of course, impact investing has so many different meanings. But I think it's got a big kick recently with the new RISE fund. And this, of course, is a multi-billion-dollar fund that seeks global impact as well as financial returns. And Jeff Skoll and Bono are two of the principals, and it's being run by the Texas Pacific Fund. It's a pretty interesting way of approaching it. They really do want to try to do well and do good at the same time, so I'm optimistic that that will make an impact. What do you think?
And thank you for the TPG. Yes, it's a fund of fund, and so it will multiply because it's not. They will then seed many impact funds, and I think that's. Thank you for bringing that up. It's very exciting.
See, thought I had, right here. Yes, middle. Yeah.
Bertolo from Boston. I follow the biotechs in Kendall Square, mainly for rare disease.
I'm sorry. Could you speak up just a little bit louder? Thank you. Yes.
Closer. I will, that sounds better. All right, so I'm interested in rare disease development, and Kendall Square in Boston is very big. I wonder, foreign investment, do they have goals in medical care? Are they interested in communicable diseases? What do you think they will invest and research?
To the best of my knowledge, which is a deductive process, because I look at what they've invested in and then I come up with their investment thesis because I'm not personally privy to it, is that they're looking at oncology, very heavily, in common chronic diseases like cardiovascular areas, and then they're looking at convergence technologies like artificial intelligence and digital health. I haven't seen any of them looking at antibiotics or at particular diagnostics, so I don't think so. But the rare disease area is a very interesting consequence, I guess, of a government act in 1984, 83, the Orphan Drug Act, where the government gave an incentive for companies to focus on rare diseases where under 200,000 Americans were affected. And there was very little investment there before because there was no money in it. Right. And then Genzyme was the poster child for making a success from there. And now it has become a vibrant area of investment and, unfortunately, hugely expensive drugs that are $100,000 a year at least.
And regulation.
Well, they got regulatory, part of the act was a level of regulatory mitigation, which brings down some of the regulations in terms of what's required. So that's an example of a government intervention, which you might not, not be in favor of, but it is follow the money, follow the incentives. And you can change things by changing incentives.
Hand, yes, over here.
this is someone who's going to help us solve the issue of diagnostics.
Hi. Anita Goel, Nanobiosim, Cambridge. What is the panel's perspective on what we can do to raise the consciousness on Wall Street about cutting edge, kind of sexy things that are good Wall Street candidates also having a humanitarian impact, also going out and going into areas of underdeveloped, where there's lack of access? How can we, what can we do? What does the panel feel we can do to kind of really push the industry in a way where it doesn't have to be a Zen paradox to be able to do something that's cutting edge, frontier, and also help billions of people who perhaps would be at the bottom of the pyramid? What is that? What do we need to do to change that consciousness?
Well, I'll make a comment on that. I think there is a model, and I agree with you. I mean, diagnostics are an important issue in the U.S. I mean, wouldn't you love it when, you know, it's flu season and you go to see your healthcare provider to actually know you have influenza versus, you know, some other virus or, you know, so I think that one of the things is there is an opportunity that, you know, we can invest in it where people can afford to pay for these diagnostics, and then, you know, those same companies could afford to give them away. I mean, it's like, you know, the Tom shoe model, you know, you buy a pair of shoes where people can afford it and you give one away, or the, you know, the glasses that, you know, Warby Parker does, you know, you buy a pair of glasses. So I think that that could be a short-term solution right now as we start thinking through those. But I believe that there is a marketplace for diagnostics and people don't realize it because we've grown up in a culture where we don't even use diagnostics in the US in a way where we could have improved healthcare here. So that's my hope in the short term, that people will get the point that diagnostics is a worthwhile investment. And then hopefully, you know, eventually either the cost will reduce enough that we can distribute it around the world, or that there'll be some ability to, you know, provide more of a philanthropic outreach from these companies who could be making money on diagnostics where people can afford to pay for them.
Lanhee, do you want to weigh in on that?
Yeah, I think part of it is where the consumer sits in this, and how the consumer is motivating the corporate actor to behave in one way or another. Because I do think that at the end of the day, you know, many of these firms are responsive to what consumers eventually want. I think it's a question of how long that cycle takes to get from the consumer to the, you know, who oftentimes is also the shareholder, to the company, and then to sort of generate that level of change.
I see just two little changes also, Anita. One is several diagnostic companies are going direct to, are making it available to the consumer at a much lower price. So if you get reimbursement for $600, if you pay directly, you can get it for $100. And the $600, you don't know what your copay is going to be, and it's complicated. So that's another thing. The other thing is, you know, can you generate some kind of index other than financial? Will society support a rating system that's not just financial performance, and will there be a, you know, I doubt it, but it's something to aspire to.
Okay, another question. Here on the second row, right here.
Thank you. Seth Cochran from Operation Fistula. As I'm listening to the panel, something's kind of popping into my mind about a profit motive being associated with systematic inequity. I mean, you mentioned that antibiotics are not a good investment market, but they're widely available, right? So what I'd like to understand is the panel's thoughts on, if we have a profit motive in this country that can attract foreign investment to the level that you're describing, do we have structural, you know, inefficiencies or inequities that are so dramatic that offer that level of profit motive? Or more simply stated, does this profit motive that we have imply big systematic problems that we have here?
I think the systematic problems are deep. They have gotten worse over time. I think at the times that the problem was that these systems were put in place in the 60s when the whole environment was different, and then investors and entrepreneurs, everybody, companies gamed that system. And it's not a pejorative term. I mean, it's what people do. And I think the misalignment of these systems has become huge now, whereas they were somewhat aligned at the time that they were put in place. And to then dismantle those systems right now would be incredibly difficult. So we are sitting with hugely misaligned incentives.
Yeah, I think the alignment of incentives, innovation, and access really depends in part on the urgency of a situation. So I think one of the challenges, and you mentioned antibiotics, is a great example of where we generally have a sense that antibiotic resistance is a problem. We generally hear it when you go to the doctor and you have a cough and you say, hey, can you prescribe a Z-Pak for me? And the doctor's like, well, not really, because you have your infection is probably viral. So we kind of have a knowledge of it, but the challenge becomes how urgent do we feel that need? And I'd argue that the greater the urgency, the more you're going to see that alignment, which kind of stinks because you don't want to get to the point where it's urgent, but that's kind of how our system works.
You may also be in a situation where in the spectrum, there are different ends in mind. So for me, it could be that I want to see more people that are actually healthy. For other people, it could be different. So because there are different ends in minds, you can't reconcile them. And I think I don't think it's possible to try to reconcile them. Is how do we find profit-making entities willing to actually share some of it, as I was earlier alluding to? Because the comment about Wall Street, they are designed for a certain purpose. Why do we want them to do something else? It's not what they're designed for. So we need to find a way to convince them that they can share some of what the returns are for something that they believe is important so that people continue to work in factories so that they can continue to make money.
Is there anything else, as we wrap up, is there anything else to be said about incentives, getting outside entities, whether they're U.S.-based or somewhere else, to invest in healthcare, and the rising cost of healthcare in this country, which is such a huge issue for us?
For this
Sure.
country?
Yes. All weigh in.
I think if we keep that end in mind to see more people healthy and to see that when they're healthier, there are better opportunities, it will help. I think looking at the debate in the US is very polarized, and we're not keeping that end in mind of what it would mean to have healthier Americans. When you look at the data in terms of number of HIV/AIDS infections in the US, sometimes you think, okay, is this the US or is this an African country? So we need to be able to understand what is it that we want as a society. And once we understand what we want as a society, we'll make those choices. And some of them will be costly because the US has been used to work in a certain way. Now, coming to where my focus has been, which is the African continent, there are changes that are certainly very interesting to watch. The youth of Africa are going to become the youth of the world. You just have to look at the demographics. It means that the issues that we face today, if we continue to think that those are African issues, we'll have bigger problems, being in health, in education, in whatever you may think about. So immigration, in a way, shouldn't be seen as a problem because the demographics are not in the favor of the rest of the world. They are in the favor of Africa.
I think that the fact that we pay the most for healthcare of any country and don't have the best healthcare in the world is a wake-up call. I personally believe in a single-payer system. And I'm also very hopeful about the millennials, who I think have a very different view of the world and will hopefully help fix some of these problems.
And maybe even invest some of them. Thank you all. What a terrific panel.
Thank you.
Thank you very much. Appreciate it.